I really just wanted to do kind of a general overview of what we do in the Women's Center. We get a lot of questions about mammography and breast imaging specifically. Out of all the departments that I oversee, which includes MRI, CT, nuclear medicine, ultrasound, the Women's Center, etc., I get the most questions about mammography. Quick facts, 1 in 8 women are diagnosed with breast cancer. This is probably not something new. I'm sure everyone in this room's probably heard this at one point in their life or not. Only about half of American women get their annual mammogram. There are some websites and statistics you can look at that are state specific, and the state of Indiana actually does much better than the national average on this. We're sitting, it's usually the number you see is between like 73 to 76% of women in Indiana get their screening mammogram. So that is great news for us as a state. Hopefully we can keep that number going up. Mammography has been around for quite some time. It really took off in the early 90s, and it's helped to reduce breast cancer deaths by approximately a third. 75% of women diagnosed with breast cancer have no family history and are not considered high risk. So that is something we get a lot of questions about, or I might even hear patients or people just in the community say, I don't need to get a mammogram, I don't have any family history. So it's really important that patients and providers understand that statistic, knowing that 3/4 of patients that are diagnosed do not have a family history. This just goes over some of the normal breast anatomy. A lot of patients or kind of non-healthcare people think it's just fat in the breast tissue, which is not accurate. There's lots of things going on in there. We've got blood vessels, lymph nodes. There is fat tissue, of course. There's also some muscles, and then the milk ducts and some fibroglandular tissue. So all of that is imaged on the mammogram or in breast imaging, and it's up to us as the radiology professionals to determine what's normal tissue and what's something abnormal that we might need to be concerned about. So what are the recommendations? This got a little bit confusing within the last 5 to 10 years because some of the recommendations had changed for a while, and now they're kind of reverting back to the old, what I call the old recommendations or original recommendations. So as of today, they do recommend a clinical breast exam every year beginning at age 20. This is typically done by like an OBGYN or within their office or a PCP's office. Again, probably most of us ladies in the room here have had this done by a provider before. A screening mammogram every year beginning at age 40. The only time we recommend a different age other than 40 is if you do have a family history, meaning a mother or a sister who had breast cancer. Then we recommend starting the screening mammogram at the age of 40 or 10 years prior to their diagnosis. So if my mother was diagnosed with breast cancer at the age of 42, we would recommend starting my screening mammograms at the age of 32. There's some other things if you are especially a high-risk patient that you had a mother, sister, or a strong family history. You can also get what they call BRCA gene testing. Again, you've probably heard about this. It got really popular in the media many years ago with this BRCA gene testing. For example, like Angelina Jolie had a full bilateral mastectomy because she was BRCA gene positive. She had a strong family history, her gene was positive, so she had like a prophylactic surgery done. It's not necessarily something we recommend, but it became very popular, like I said, in the media. So gene testing has really taken off really since then in the last 5 to 10 years. Additional screening is also available if you're high risk or if you have what we call dense breast tissue, which I'll get into here shortly. So mammography is unique in the world of imaging because it really only has one purpose. We're only looking for one thing, and that is breast cancer. Very different from, like, for example, if we do a chest x-ray, there's hundreds of things we're looking for on a chest x-ray, from pneumonia to broken ribs to heart problems, etc. For mammography, we're only looking for breast cancer. That is truly only its purpose. It's a very low dose of radiation. We measure radiation in millisieverts, which is what the MS there is, which means absolutely nothing to anyone in this room, and that's okay. So what they normally do for radiation dose is they try to explain it by equating it to what you would get by just sitting in this room. So we are all getting some natural background radiation just by sitting in the room today. The Earth's crust, and there's radiation kind of floating around in the air. So they usually will relate, like I said, a x-ray exam to how much you would get by sitting in a room. So a mammogram is about 2 months of normal background radiation, which is very low, especially if you compare it to like a CT scan, for example, which is about 2 years worth of radiation, depending on the type. Of course, if you've had a mammogram, you know we don't want you to wear deodorant or any powder on your underarms or under your breast tissue because those powders and deodorants can mimic the look of certain breast cancers. So that is why they ask you to remove that. We don't want to think something is a cancer when it ends up just being whatever deodorant you're wearing that day. Mammography typically takes about 15 minutes. It can take a little bit longer if you're more challenging to position. For example, patients who are in wheelchairs, we do a lot extra time for those patients. Or if you have breast implants, which require some additional views, so a couple extra pictures. So we make sure we allot time for that as well. And then probably the number one reason that we get why people say I don't want to have a mammogram is because they're afraid it's going to hurt. They have fear of that pain related to the imaging. So 65% of women have no complaints of pain during their mammogram. And that's important because, like I said, a lot of people don't get a mammogram because of that reason. Now I know you're looking at that thinking, well, what about the other 30+% that say it does? There are things that we can do, and especially with the technology we have today is much improved from the technology of even 5 years ago. But there is things that we recommend if you are a patient that either has anxiety about the mammogram, who's concerned about the pain, or maybe you've had one before, you know you're going to get it, but you're kind of dreading it because maybe it does hurt for you. So a couple things, if you schedule your mammogram a week after your period, if you're still having periods, our hormones play a big role in the breast tissue's response to pain or how kind of sensitive it is during the imaging. So scheduling it around those hormone fluxes can make a big difference. Avoiding caffeine for up to a week before your mammogram. That includes sodas, chocolate, which always makes people cringe a little bit, but it does make a big difference because caffeine can cause, again, that breast tissue just to become more inflamed and just more sensitive to the mammogram. And of course, an easy one, take a Tylenol about 20 minutes before your mammogram. A Tylenol is an anti-inflammatory. It helps calm our tissue down and tends to make the mammogram much more tolerable for patients. And then just tell the technologist, the mammographer who's taking the pictures, if you are anxious about it. They have different techniques they can use to help minimize discomfort during the scan or during the imaging exam. And then our equipment that we have nowadays too is much more comfortable, again, than what it used to be. So if you haven't had one for 10 years or so, I'd say go try it again because it's probably going to be a very different experience than what it was many years ago. So this is a very big question that I get, or a very common question I get, is related to screening mammograms versus a diagnostic mammogram. So for the patient, the imaging technique feels very similar. The machine is the same. Some of the views are the same, but not all of them. But a screening mammogram is just what it sounds like. You're not having any problems. It's kind of your annual exam, and you're having it every year just because you're supposed to have it every year, not because you're having any kind of issue. A diagnostic mammogram is a type of mammogram that we do when you are having a problem. So maybe you feel a lump or a bump, or you've had a change in your breast tissue that you're concerned about. Or maybe you already had your screening mammogram and now we're calling you back because we saw an area of concern. Those are the reason you would have a diagnostic mammogram. Sometimes you'll hear it called spot imaging because we're focused on a particular spot within the breast. And so the biggest reason patients question this, and even some providers, is because typically a screening is covered by your insurance. It's part of your annual exams. Typically no out-of-pocket for these. A diagnostic is not typically covered under your insurance as part of an out-of-pocket cost. So it goes towards your deductible. So that is something that we get a lot of questions about. Patients will go and have a mammogram because they have an area they feel, and now they're getting a bill that they didn't expect possibly. Or they're saying, well, normally my insurance pays for my mammogram, why didn't they pay for it this time? And that's probably the #1 reason why. So callbacks, this is another question we get a lot from patients, or it really just causes a lot of anxiety because patients get called back after they have their screening mammogram and maybe the radiologist finds a change or something that they're concerned about. We will call back the patient to the Women's Center for some additional imaging over that specific area. This is typically nothing to worry about. I know that's a lot easier said than on our side than for the patient. But the thing to remember with this is mammography cannot distinguish between normal changes and abnormal changes. So as we age, just like the outside of our body changes, the inside of our body changes too. So sometimes from one year to the next, your breast tissue may change, or there might be an area within your breast tissue that appears to have changed on the mammogram. It could just be a normal change for you that's happened over time. But we always have to be concerned about those abnormal changes, and the additional imaging that we do is what allows us to determine if it's something we need to be worried about versus something that, oh, that's just a normal change for you, we don't need to do anything else with it. So when can people stop having a mammogram? We have patients often ask, they might say, I'm getting older and when can I stop doing this? There really is no defined age limit on mammography. The best answer that radiology or radiologists will give you is if you would seek treatment, if you were diagnosed with breast cancer, then you should get your mammogram. If you are 90 years old or 20 years old, well, 20 is a bad example, 90 or 40, we'll say. Because if we find an abnormality, the whole idea is to catch breast cancer early and treat it. There are some patients who are very young who have, comorbidities or who have other health problems that say, you know what, I know I'm not very old, but I have all this other stuff that if I got diagnosed, I probably wouldn't do anything about it. That being said, breast cancer in particular is a very treatable cancer, especially when it is caught early. So there again, if it really isn't an age limit, it's just based off your other overall health and how you would treat it if something was found. A really popular topic related to breast imaging over the last 5 years, it seems like it's become a topic of discussion. So really all breast density is the percentage of fat tissue in your breast related to the percentage of the glandular tissue within your breast. So if you have more glandular tissue than fat, you have dense breast. So I'll have a good picture here in just a minute to show you. So dense breast is a very common thing. About 40% of women have dense breast tissue. It's not a unique problem, so to speak. Typically our breast density will decrease as we get older. So again, just like our bodies change on the outside, our bodies change on the inside. So if you have dense breast tissue 1 year, 5 years later, you might not have dense breast tissue anymore. That's not uncommon for that to happen. And certainly our breast tissue can change with certain hormone medications as we get older. If some patients start taking certain hormone medicines, it can cause them to have an increase in the glandular tissue of their breasts and make their breast tissue more dense. And also weight loss and weight gain can significantly change the type of tissue that you have in your breast. In fact, we've had many patients over the years who have had such a significant change in their breast tissue, we have to call the patient sometime and say, have you had a significant weight change over the last year? Because their breast tissue looks so different from year to year. And most of the time they say, oh yeah, I lost 50 pounds. It's like, well, that's wonderful for you, but your breast tissue looks really different. So it makes sense to us now. One thing though with breast density is why it's important and why we talk about it is because it can decrease the sensitivity of your mammogram. So this is why, and I don't know how good you guys can really see this, but there's 4 categories, and the state of Indiana requires us to put your breast density on your radiology report. We also have to send every patient a letter after their mammogram, and that will also include your breast density. So if you're sitting here thinking like, I don't even know what my breast density is and how am I gonna know? If you have my chart or if you have your letter from your last mammogram, it will tell you what category you are. So AB, category A, category B are considered just normal breast tissue, not dense. If you are category C or D, then you would be considered to have dense breast tissue. And the reason this is important is because you can see the category A, which is mostly fatty tissue, is more of a dark gray color all throughout, whereas the very or extremely dense is more white. And where this comes into play is because a breast cancer or a breast mass will show up white on a mammogram. So if you take a white mass and plunk it down in the middle of this breast, you're going to see it very easily, or the radiologist will see it very easily. If we take a white mass and put it in the middle of this breast, it's going to be a lot harder for them to see. So that's why having that dense tissue can decrease the sensitivity of your mammogram, because it makes it much harder for us to see on those types of images. I'm going to skip past this. 3D imaging is something we added at Memorial back in 2018, so we've had it for many years now. It is it is the gold standard of imaging, so pretty much everywhere we'll have 3D imaging these days. There are still some 2D out there, but I'm going to kind of skip past that just because pretty much everybody's using it at this point. So there's a couple different things, like I said, that we can see on a mammogram, and it's not just breast cancer. Even though that's only what we're looking for, so we find other things too. So calcifications, we can get calcifications in our body as we age, and it can be anywhere in our body, but we do see them in the breast. These can either be benign, which is not cancer, or malignant, which is a type of breast cancer. So calcifications are the earliest form of breast cancer that we see on a mammogram, and it can only be seen on a mammogram. So every now and then patients will say, I don't want to get a mammogram, can I just have an ultrasound instead? Or I don't want a mammogram, I'll just do an MRI. You run the risk by doing that. If we skip past mammography, we are going to miss breast cancers because there are this type that only show up on that specific imaging tool. So, like I said, there's a lot of benign things that we find, which include cysts, which are by far the most common mass we see in the breast, and it is a mass. So sometimes we call patients back and say, oh, the radiologist has seen a mass in your breast, and we hear the word mass outside of healthcare and we think, oh God, mass means cancer. Not necessarily. There are a lot of benign masses or not cancerous masses that we see as well. And then also just fibrocystic changes are something that occur over time, typically as we age. Fibroadenomas are very common. They are a benign breast mass. And then sometimes we do see lymph nodes within the breast tissue too. I'm sure all of us in here, if you've ever gotten a really bad cold, you can feel those lymph nodes in your neck. They do extend down into the breast tissue some. So every now and then we find a breast mass on your mammogram, and then we do some additional imaging and realize, oh, it's a lymph node. So that does happen as well. And then of course, what we are really looking for is sometimes we find breast cancers too. So this is something I really want kind of the general public to know, because we call a lot of patients back for additional imaging, and most of them turn out to be nothing, which is super frustrating for patients. They're like, why are you calling me back? And then it turns out to be nothing. But like I said, there are certain things that we have to do additional imaging of in order to determine, is this a cancer or is it one of those abnormalities that isn't a cancer and it's okay to have, but it's still something that's showing up on the mammogram. So for every 1,000 mammograms that we do, so 1,000 screening mammograms a year, or that we do, 100 of those 1,000 will be called back for additional imaging. So it's not uncommon to get called back. 20 of those 100 will then have to have a biopsy, because maybe we've done additional imaging and we still can't be 100% sure that this is not a breast cancer. So the only way for us to know that is to do a biopsy. So 20 of those 100 will have biopsies. Out of those 20 that have the biopsy, only 5 will be diagnosed with breast cancer. I say only loosely, because if you're one of those 5, that's a big deal. But the vast majority of patients who get called back, or even the majority of patients who have a biopsy, that biopsy ends up being benign. There's lots of different ways we do breast biopsy. They can be done under mammography, under ultrasound. Sometimes, even if we don't use imaging, they'll recommend what we call a surgical biopsy. That is kind of the last resort, so to speak. We'll always try to do the path of least resistance first in order to get patients the answers they need. So there's a couple imaging modalities we use for breast imaging or to look for breast cancer. Again, these have really taken off. Like when I started in radiology almost 15 years ago, we weren't doing breast MRI at all. It wasn't even a thing. And even breast ultrasound was kind of in its infancy, so to speak. Mammography continues to be the gold standard, and it's always where we start. We always want to start with mammography, but there are some additional tools that we use, and breast MRI is one of them. This is something that we do at Memorial Hospital. We offer this. The main reason for breast MRI is it has a much higher sensitivity, meaning it's going to find a breast cancer much easier than a mammogram, with one exception, which is those calcifications that I mentioned. The problem with higher sensitivity, though, is it's finding more cancer, but it's also finding more of everything else. So you're much more likely to get called back or to have to do additional testing if you have a breast MRI. The good thing is there's no radiation, so sometimes if we have MRI is used a lot for pediatric and pregnant patients outside of breast imaging, but that is one pro to this, is you're not getting any radiation if you would have an MRI. Some of the reasons we would not want to do an MRI, or why everyone's not getting an MRI, is because it's very expensive. Typically it's in the thousands of dollars range, and it is rarely covered by insurance. There are some that will, but it is somewhat challenging to get insurance to pay for a breast MRI. It's uncomfortable. You can see from this picture the patient has to lay on their table or lay on their belly on our table. Sometimes the arms are down at the side like that, like they're shown in the picture. Sometimes they have to be up above their head. If you've ever had an MRI of anything, you know it's not a real comfortable machine to have to go into to start with, let alone laying on your belly on this extra piece of table, and it usually takes about an hour. So we have an hour and a half time slots for breast MRI right now. The actual scan, it takes about 45 minutes, but it takes a little time to get people prepped and positioned the way we need to. So definitely a big challenge for a lot of our patients is even just getting positioned for these. The other con to this is it's invasive. You do have to have an IV, which includes a contrast injection for breast imaging under MRI. And then of course there's some contraindications. MRI always has contraindications. If you have any kind of certain implants, can't go in there. If you have any kind of metal within your body, certain types of surgery limits our abilities to do MRI, etc. So breast ultrasound or breast volume scanning, we do focused ultrasound at Memorial. We do not currently do volume ultrasound. This is another screening tool for women with dense breast along with MRI. MRI is much more specific and typically the tool that we recommend. We've had a lot more positive feedback from breast MRI for screening tool rather than the ultrasound. But there are some good things about it. Again, no radiation, just like the MRI. This is typically covered by insurance, but again, it kind of depends on the plans. Like some plans are on board with doing this as a screening tool, some have to pay out of pocket for it. It also has increased sensitivity, just like MRI does, in a little bit different way. There are no contraindications to this, so as long as you're able to lay on your back, we can do the ultrasound. If you have a pacemaker or implants, it doesn't cause any problems related to the ultrasound. And it is fairly comfortable, especially when you compare it to laying on your belly in an MRI. The biggest con with this is we did used to have one of these machines, and we had a very large number of callbacks related to this. It was finding a lot of things that ended up being nothing. But it does find breast cancers too. So. And then the other con is we cannot see those calcifications. Like I mentioned, we would not be able to just do the ultrasound in place of a mammogram. It's really intended to be used in conjunction with the mammogram. And then just some things about the Women's Center. So these again are just kind of some things I thought about that I thought I really want people to know some of these things about us. 90% of our screening mammogram results are available in MyChart the same day of service. So especially if patients have had imaging done outside of Memorial, like maybe you had a mammogram done in Evansville and now you came to Memorial this year, we do have to get those prior images from other facilities, so that sometimes can delay results a little bit. But if you have consistently gone to Memorial every year for the last 5 years, like I said, majority of the time those results are available same day. Patients can self-schedule, again, via MyChart. So if you are due for your annual screening and you haven't seen your doctor yet, or you realize, oh, I forgot to schedule that, you can do that through MyChart now. It's very easy. It's actually just like scheduling for your PCP visit. So I tested it out. It was pretty easy. Abnormal results and additional imaging needs are discussed with patients either by phone or in person by someone in the Women's Center. So this is a question we get a lot from providers because it is very different from how we handle other imaging modalities or imaging like CT and MRI. So if you have an abnormal screening mammogram, we in the Women's Center will take care of reaching out to the patient and getting them scheduled for any additional follow-up. The only time we would be reaching out to the providers is if we would need a new order, and then those results will also always go to the provider, but it's not on their plate to necessarily have to follow up the patient as needed. And then our breast imaging navigator. So this is a role that we created probably, I think it was 2019, that we started our imaging navigator program. And it was really because mammography is complicated. There's a lot of different types of mammograms, insurance complicates it, and just trying to get through the pathway of screening, and now it's abnormal, and now I have to have a biopsy, and then what do I do? So we really created this navigator position to help guide patients through that process. So if you have an abnormal mammogram, our navigator steps in and helps get you scheduled for your next exam, helps work with your primary care provider if needed, and should your biopsy end up being a breast cancer, she also then will take the next step to get you set up for appointments for oncology, for surgeons, all of those things that have to be done but are just complicated for patients to have to try to manage themselves, especially when they're having the anxiety of a cancer diagnosis. So our imaging navigator, who works out of the breast center, communicates and essentially hands off patient care to an oncology navigator at the time that they begin their treatment planning. And that's been a very successful program. We get a lot of positive feedback from patients on that. So at the end of the day, the best protection is early detection, and that's what the Women's Center aims to do every day, is to find those breast cancers and find them early.